Two.
Hi, welcome to the Elder Care Lunch and Learn today. My name is Terry Weber. I am with the Department of Work Life in the Elder Care section. And today we have Richard McQuerry with Senior Benefits Alliance, and he's going to help us how to navigate Medicare for our older loved ones. Richard?
Thanks, Terry. Thank you all for being here today. I have, just real quick about me, I've been in the Medicare business for a little over a decade now and have built my expertise in this area at maybe 5,000 or 6,000 kitchen tables over the state of Kentucky and Tennessee over the years. And, you know, my objective always when I meet with people about Medicare is to try to help make a little more sense. I always feel like it's a victory when I leave and when people say, gosh, I think I understand this a little bit better. So that's what we're going to try to do, is just to trim some of the fat and get down to the basics, and hopefully you walk out of here with a little bit better understanding how Medicare works. So what we're going to do today is, you see this slide that's up here. This is kind of my roadmap to Medicare. And I know there's a lot of stuff up there. And so we're going to kind of go through some slides and break it down. How does Medicare work, and how are the plans that come alongside Medicare to help you reduce your risk, reduce your out-of-pocket costs, and those kinds of things. That's what we're going to look at today. So first things first, I like to really make sure we have some definitions and some, basic understanding. We're all standing on the same ground. Because one thing that I've learned over the years is there could be a lot of misconceptions about Medicare and how all of this works together. So we start with what is Medicare. So if you're 65 or older or on disability, you quite likely have Medicare A and B. There's a sample card here. Medicare has been around since 1965, and as a result has a kind of an archaic setup, kind of an old-fashioned setup where they've got this Part A and this Part B. Part A covers hospital and Part B covers medical. And really, to define that a little bit better, Part A covers room and board in the hospital, and Part B covers pretty much everything else. Now, in order to earn Medicare, you have to have paid in over the years. So any job you've ever had, you see that Social Security deduction, you see that Medicare deduction that's being paid in. If you work for 40 quarters, earn enough credits, then you are awarded Medicare now. So that means the Part A is what you've earned. That part's free. The Part B, Medicare, has premiums, currently $135.50 a month. And they deduct that from your Social Security. Now, some people, there's scenarios where maybe you're on Medicare, but you're not drawing Social Security yet. In that case, they can, they'll bill you quarterly for it. And also this premium, I will note very quickly, is based, that's the standard rate for Medicare. There are situations for high income earners, and it's pretty high income earners in retirement, that they actually will charge a little bit more than the $135. But for the vast majority of seniors, they're looking at $135.50 a month taken out from their Social Security to pay for Medicare Part B. And so the question is, well, what do you get for that? What do you get for $135.50? You get a federal insurance program administered by CMS, Centers for Medicare and Medicaid Services, and it's an 80-20 co-insurance program. And so I make the point of saying co-insurance. That's a word I like to define. Co-insurance means percentage. It sounds a lot like co-pay, which is another common health insurance word, and that means dollar amount. But for right now, we're going to talk about co-insurance. So Medicare is an 80-20 co-insurance program, and they pay the 80, and you're responsible for the 20%. But that's after the Part A and Part B deductibles. Part A has a deductible of $1,364 this year. Part B has a deductible of $185. Deductible means that's what you have to pay 100% of out of pocket before the 80-20 takes effect. So every year, January 1st, that deductible resets. If your Medicare starts in December, bummer for you, you've got the deductible in December, and then you get to have it again next January. So first you pay the deductibles, and then you have the 20%. And I tell a lot of my clients to say, look, $185 deductible, that's not too bad. That's lower than most insurances that are out there in the world. $1,364, that's a little more inconvenient. But the real problem for seniors, in my view, is the 20%, because 20% is an unknown, it's a question mark. And in my experience, most seniors are now transitioning to fixed income lifestyle, and so they want a fixed budget. They would like to know exactly what is going out because they know exactly what's coming in. And so as a result, what we want to try to do is eliminate these question marks. 20% of what? Now, I don't know how much an MRI costs, so I don't know how much 20% of an MRI costs. And there's a reason, medical bills is the #1 reason for bankruptcy still in this country today. And, it's not changing. Healthcare costs are on the rise. So 20% of a big number is still a big number, and that's enough to wreak havoc on your retirement plans and things like that. So we try to avoid that. The good news is there's some really easy ways to do that. Yes, question.
Okay. Can you lower your payment based on your Social Security payment?
Can you lower your payment based on your Social Security payment? You're talking about the $135 Part B premium?
Whatever. In a sense, my Social Security is $350.
Okay. So there is income-based assistance programs. Can you lower your premium based on your Social Security? There are government assistance programs based on income, but it's based on your total household income, not just your Social Security. And there is an asset element also. It's actually one of the last slides we get to. I'm going to hit a couple of those assistance programs. So we're at a fork in the road. Not that kind of fork in the road, this kind of fork in the road. I try to get people that are new to Medicare to envision a fork in the road. There's two very common ways most people solve the issue of that 20% in those deductibles. If we go to the left, we're going to look at adding to Medicare. If we go to the right, we're going to look at replacing our Medicare. Those are two ways that most people solve Medicare. Now, this is not discussing, I know UK retirees, you guys have group retirement. That's not really what we're talking about today. We're talking about people that do not have, VA benefits is something a lot of people use as an alternative. Group retirement benefits would be the other common one. But these two are the ways to minimize those costs. So let's head left. Let's take a look at what it looks like to add to Medicare. This is what we call Medicare supplement, or you heard it referred to sometimes as Medigap insurance. It's the exact same thing. Sound different, you think they might be different, it's the exact same thing. Medicare supplement is Medigap. And CMS, again, Centers for Medicaid and Medicare Services, that's the branch of the federal government that oversees Medicare as well as Medicaid. Every year they're nice enough to put together this nice manual called Medicare U. Some of you maybe are familiar with this. They send you a copy in the mail. You can download one for free on the internet. This is the cover of the 2019 version. And it is chock full of wonderful information. Lots and lots of information. Difficult sometimes to get through, and that's why I'm here to try to condense some of that information. But there is a chapter in there that obviously discusses Medicare supplement plans. And what you'll learn is there's several different Medicare supplement plans. And they call themselves, just like Medicare, to make it nice and confusing, they call themselves by letter also. There's Plan A, Plan B, Plan C, D, F, G, K, L, M, and N. And this is, I think, on page 76 inside the Medicare New booklet this year. And this is the chart that they give you to help you decide which plan to go with, which one's going to fit your needs. Now, I remember, I don't know about you, but I remember the first time that I saw this. I had actually been a financial advisor. I've got 2 degrees from here at UK, one in finance, one in economics. Fancy myself pretty good with numbers. Had been in the insurance and financial business, financial services business for about 8 years, and was going to get into Medicare. And thought, well, this will be a piece of cake. And I started learning about this stuff, and I came across this chart and thought to myself, my goodness, this is the most complicated thing I've ever seen in my life. If I struggle to understand and decipher what this is telling me, I can't imagine how difficult it must be for seniors, especially when this stuff changes pretty frequently. So what I do is try to trim some of the fat. So we're going to talk about just 3 of those plans. That helps us narrow it down a little bit. The reason I do that is because what you'll find is most of the insurance carriers, there's about 50 or 60 in the state of Kentucky, probably double that nationally, that sell Medicare supplement to seniors. Most of those insurance providers, carriers, will only really offer 3 plans, F, G, and N. Some of them will, a lot of times they're obligated to offer Plan A. Some of the plans will offer some of those other letters that you saw, or some of the insurance companies will offer other letters. But in all my travels, I can count on one hand how many times I've seen something other than an F, G, and N. So we're going to focus mostly on the F, the G, and N. They are overwhelmingly the most popular plans that are out there, and you'll see why in a moment. Plan F, I call the Cadillac plan. It's often referred to as that. It covers 100% of everything. All of those costs, the Part B deductible, the Part A deductible, and that 20%. Plan F covers all of that. But it is the most expensive plan, as Cadillacs all want to be. So sometimes, people say, well, that's maybe just a little outside my budget. Is there something maybe a little more affordable? And I said, well, yeah. Let's take a look at the Plan G. Very popular plan. Plan G says, well, we're going to ask you to cover that $185 deductible, that Part B deductible each year. And if you, the patient, the member, if you'll cover that, we'll cover everything else after that, just like a plan. And as a result, it's a little more affordable. But still, there is another option out there that is attractive to some people, and it's the Plan N. And just like the Plan G, it says that you have to pay the $185 Part B deductible each year. And then after that, for the remainder of the year, you'll have a $20 copay at the doctor and a $50 copay at the emergency room. And then it covers 100%. There's a little bit of an asterisk there. I don't want to get into the mud there too much. There's situations sometimes where doctors can charge an excess charge to Medicare. If they don't take Medicare assignment, Plan N doesn't cover that. There's not very many doctors that do that, so I don't spend a lot of time on that. But if somebody is interested in Plan N, I can explain that a little bit further. But just as a disclaimer, there is kind of an asterisk on that 100%. And as a result, the Plan N is a little bit less expensive than the G. Now, I use generic dollar signs here because it depends on your age, depends on your gender, depends on what state you live in, where inside the state sometimes. A lot of these insurance companies will break down their premium rates by what zip code you live in, because they'll know that, well, this part of the state is in general healthier than this part of the state, things like that. It can depend on if you are a tobacco user or not. They'll charge different rates. And different companies charge different rates. So by and large, that's what you're looking at. Just for illustration purposes, for a 65-year-old male coming into Medicare in the state of Kentucky, this is probably not too far off from other states. You're probably looking at, for Plan F, somewhere around $150, $160 a month. Plan G is maybe closer to $120 to $130 a month. And Plan N is maybe somewhere in the neighborhood of $100 to $110. So, couple of points I like to make about Medicare supplement. Things that are true about all Medicare supplement plans. Number one, these plans are standardized by CMS, and that's very unique in the insurance world. The federal government actually defines what these plans are. So the way that I've described them to you, if you remember back to that big chart, it describes all of the plans. The federal government is the one that actually says, here's what these letters are going to mean, here's what they're going to cover. The insurance companies simply offer that plan at whatever price they want to offer it at. So what that means is, for you, this is a good thing, a Plan G is a Plan G no matter where you get it from, okay? It's going to work exactly like the way that I've explained to you, because that's what a Plan G does. This helps so that you take out a Plan G with one company and you're very satisfied with that, and This way somebody can't come along, maybe some insurance agent can't, come along and say, oh, you've got company X plan G? Oh, you should have my plan G. It's way better. We've got all these extra bells and whistles. Well, then it's not a plan G. So this helps you a little bit more compare apples to apples, which is a good thing. So number 1 point, these plans are standardized by CMS. Number 2, what that means is we're primarily making our decision based on the rate as well as the reputation of the company. And what I mean by that is, I mentioned kind of average rates, but one of the things that's important to realize is that Medicare supplement insurance is built to go up every year. Your rate will go up. Now, industry-wide, we try to say, we're hoping for somewhere in the 5%, give or take, range per year. Some companies have better reputation than other companies, but we don't have a crystal ball. Over the years, I've seen really good companies have a bad year and all of a sudden have a fairly significant rate increase for their members, and that's never pleasant. But it's worth noting, when you're going into a Medicare supplement plan, just know that rate is going to go up in time. Point number 3, Medicare supplement plans do have health questions. These plans are secondary insurance, so the application does have health questions on it that trying to ascertain your current health status. Things like, do you have diabetes? Have you had a heart attack in the last 3 years? Do you have congestive heart failure? Do you have emphysema? Do you have Parkinson's disease? Now, the good news is there are a couple of loopholes in that. There's a couple of get-out-of-jail-free cards, if you will. The most common one is when you're turning 65 and you're brand new to Medicare, you get to skip the health questions. There's about a 7-month window that opens up that you don't have to answer those health questions. So if you have health problems, fear no evil. You can jump into the plan at 65. There's actually a couple of other occasions when you can jump into a Medicare supplement plan, no questions asked. Those are kind of isolated situations, like maybe leaving a group retirement plan can sometimes apply, and other situations that I won't get into right now. But suffice it to say that there are underwriting. So one of the biggest misconceptions I run into is people say, especially this time of year as we approach the annual enrollment period, people say, well, I can change my plan every year. So what if I get a plan and, like you say, the rate goes up and it gets really expensive? Can't I just change to another Medicare supplement plan? The answer is maybe. Because now you are no longer what's called guaranteed issue. You are going to have to answer the health question. If you can pass the health questions, then yes, you can switch to another company that maybe has a lower rate. If you cannot pass the health questions, then you may be stuck in the plan that you've got for the time being. A little bit of good news is that Medicare supplement plans are obviously targeted to 65 and older, so the health questions aren't impossible. They know their target market. They're mostly trying to avoid chronic issues that they know that would be expensive, forever and ever. But that's how that works. Point number 4 is Medicare supplement plans do not have a network. You can go to any doctor in the United States of America that accepts Medicare, and they have to accept your Medicare supplement plan. Routinely, I will hear something like, well, my doctor doesn't accept XYZ. Let's say, and I'll say, well, they will accept Blue Cross Blue Shield's Medicare supplement plan because they accept Medicare. They might not accept Anthem group insurance. They might not accept Anthem Medicaid or some other form of Anthem insurance. There's lots and lots of different health insurances out there. Medicare supplement, any doctor in the United States that accepts Medicare must take your insurance, and that goes for all hospitals.
So that would be better than for snowbirds, like people who leave the state in
So the question
winter?
is, would the Medicare supplement plan be better for snowbirds? Let's talk about that in a minute, because we don't know what it's better than.
Got it.
But we're going to get there. Point number 5, our last point here, is there's limitations. So Medicare supplements only pay when Medicare pays. So you'll notice, if you go back to our initial conversation about Medicare, there's a Part A that covers hospital and a Part B that covers medical. Well, what's missing from that list? Maybe prescription drug coverage? Yeah, that's not covered by Medicare, so it's not covered by your Medicare supplement plan. What about vision and dental? Not that either. What about elective surgeries? No. If Medicare does not cover it, then your Medicare supplement is not going to cover it. The best example I have, and I'm sorry because it's actually a little dated. I do believe Medicare actually covers this now, but I still think it illustrates the point. About 9 years ago, I met a woman and she needed back surgery. Her local doctor was going to perform the old-fashioned nuts and bolts surgery, and Medicare would have covered that, and her supplement would have paid the other 20%. She would have been out of pocket nothing. But she had done her homework and decided, I only have one back. It's pretty important. This type of surgery has lots of issues, lots of complications, lots of healing. She said, and there's this new place called the Laser Spine Institute, and they do this laser surgery. It's very non-invasive. The healing is supposed to be wonderful, and it's just supposed to be the best ever. At that time, Medicare did not cover laser spine surgery. So her supplement was not going to cover any of it. It was $17,000, and she said, you know what, I have $17,000, and it's my back, and I'm going to pay for it. And she went, she did it, and more power to her. But worth noting, if you're going to have some kind of elective surgery or something like that, it may be worth asking the doctor or the surgeon in the billing department, is this going to be covered by Medicare? One little point that's worth noting, because there's been a law change, there's been a little bit of change here. We talked about Plan F as the Cadillac, Plan G, and then Plan N are kind of the next two step downs on the ladder. But there's a change that's coming. Starting January 1 of next year, Plan F is going away for people new to Medicare. So if you currently have Medicare, you will still have access to Plan F. If you currently have a Plan F, you will keep your Plan F. But one thing worth noting is the way that insurance works is everybody's sharing the risk. And so if there's no new people jumping into the Plan F, no new young 65-year-old, healthy 65-year-olds joining this risk pool, we call it, then the rate increase we expect will not be 5%, but probably we think it's going to be more than that. And as a result, as time goes by, the healthy people that have Plan F are going to say, you know what, I'm going to jump out and maybe go with a nice Plan G. And so that leaves only the sicker and sicker people in that Plan F. So one of the conversations we've been having with a lot of people, just a strategy to consider, if you or a loved one have a Plan F, it may be worth a conversation to see what it looks like to move to a Plan G. My advice to my clients for years now has been that the Plan G makes a little bit more sense anyways. Typically, the Plan G is usually about anywhere from $20 to $40 less expensive than a Plan F. As a result, let's do some quick math. Let's just say it's $30 cheaper, okay, than a Plan F. Well, 30 times 12, you're saving $30 a month on a Plan G. Over 12 months, that's $360. $360, you're saving more than what you're giving up, which is the $185. I know I'm saying a lot of numbers right now, but essentially I'm saying it's worth paying the $185 deductible on a Plan G because you save more than that in the reduced premium. So I have advised Plan G over Plan F for years. Now that this new law change is happening, we're trying to encourage even a more closer look at that. So again, if you or a loved one has a Plan F, it may be worth time to take a look at that. So that's Medicare supplement. Let's get back to these limitations. It doesn't cover prescription drug coverage, so we have to go add prescription drug coverage. You hear about Part D coverage, or sometimes with shorthand PDP, Part D plan or prescription drug plan. This is an add-on to your Medicare and your Medicare supplement plan. And it's going to be similar to what you're probably used to seeing. It's going to be a tiered copay structure. Prescription drug plans are going to range anywhere from in price from $20 to there's some that are $80 and more a month. The average nationally is about $30 a month for a prescription drug plan, so you can anticipate adding this onto the cost of your Medicare supplement. Now, I do sometimes get people that say, well, I don't take any medicines. Maybe I'll take a drug plan out later in life. That's fine, but do know that they do penalize you. When you do take that plan out later in life, they will penalize you 1% of the average national cost per month for every month that you did not have a prescription drug plan. So it's a retroactive penalty that says, hope you enjoyed not paying for a drug plan all those years. Now you're going to make up for it. Yeah. And so the way that the drug plan works, there's 4 stages. First stage, most drug plans are going to have a deductible of some sort. Some plans do not, but many plans do have a deductible. It can be up to $400 and change. A lot of them are less than that. So first you pay 100% of whatever your plan's deductible is. Then you reach the tiered copay stage, which they call initial coverage. Most plans are going to do like generics are typically like your tier 1 and tier 2, and your name brands typically will fall in your tier 3 and tier 4. And then a lot of plans will have a specialty tier 5 for infusion drugs. Then there is a stage after that. Okay, if you are someone that uses a lot of prescription medication or needs a lot of prescription medication, the tiered copays end and you go into what's called a coverage gap, or commonly referred to as the donut hole. Now, you can come out of the donut hole and actually reach stage 4, which is catastrophic. Let's talk a little bit more about what the donut hole is. If you require $4,000 this year, it's $4,020, and that's the wholesale price, not what your copays are, but the total cost of the medication. If you use $4,020 worth of medicine in a year, you no longer pay your copays, but you go into the coverage gap with the donut hole. At this point, you pay a percentage of what the wholesale cost is. There's a lot of math that I don't want us to get into today. Suffice it to say, right now, the way that the donut hole works, typically name brand medicines are going to get more expensive when you're in the donut hole. Some medicines will get quite a bit more expensive. Think of things like insulin pens, inhalers are some of the more common ones. Heart medications, brand name heart medications can get pretty expensive in the donut hole. So it's not referred to as nicely as the donut shop down the street. Most people kind of grimace when they hear about the donut hole. But the good news is you can come out of the donut hole. If your total spend gets to $6,350, and again, there's some weird math that goes into this and some discounts and rebates from the manufacturers, but it's based on the wholesale. So it's not like you have paid out of pocket $6,350, but the total cost of medications. You go into the catastrophic phase. This is what I call the I'm crying uncle stage, because once you get here, they give you a break and they say, okay, your generic medicines are going to be $3 and change, and your name brand medicines are going to be $8 and change. So there's a happy ending to the story. So that's prescription drug coverage in a nutshell. So I get a lot of seniors ask me, well, I've got glasses. I need to get, I like to take care of my teeth. I may need hearing aids and things like that. So people will ask about vision and dental most commonly, but sometimes other insurances as well. So let's kind of recap real quick. So far we've talked about Medicare. And if we take the left-hand path on our fork in the road, we're going to add Medicare supplement to that. And we're going to add prescription drug coverage to that as well. And if you want vision or dental coverage or any other kind of coverage, you're going to have to add that too. We're walking around with a whole lot of insurance. That's really how this side of the path works. We just talked about add to. If you want to add to Medicare, that's what that looks like. And as we just found out, there could be a lot of adding to, depending on how much peace of mind that you want. So now let's take a look at the replace side of the equation. Replace, sometimes referred to as Part C. You'll see this in CMS literature a lot. They refer to it as Medicare Part C, but its technical term is Medicare Advantage. And these days, many of the plans also include prescription drug coverage. And so shorthand in the business, we refer to it as MAPD, Medicare Advantage with prescription drug coverage. Basically, going back to that old co-insurance word, basically Medicare Advantage plans are trading co-insurance for co-pay. These plans are going to be a private insurance. Instead of getting the federal government to provide your health insurance, you're opting to have a private insurance company provide your health insurance. And what does that look like? Well, here we go. Medicare Advantage plans are, sometimes I've heard people refer to them as all-in-one plans. Medicare subsidizes the plan and oversees these plans. So private insurance company X decides they want to offer Medicare Advantage in your neck of the woods. Well, they have to submit their plan to Medicare for an overview. And Medicare is going to say, oh, we will reimburse you, or we will subsidize you to offer this plan in that area. But it has to meet a couple of guidelines. Number one, it has to be at least as good as original Medicare A and B. Most of the plans, I would say, in my estimation, far surpass that these days. So they're going to include your hospital coverage, your doctor coverage. They're going to include prescription drug coverage, I mentioned. A lot of plans these days also are going to offer at least some kind of preventive dental and vision coverage and additional ancillary coverages. Could be hearing coverage. A lot of plans are doing transportation, over-the-counter allowances, and all kinds of bells and whistles. Some of the plans are doing personal emergency alert systems and things like that. So they package all of that into one plan. You don't even use that red, white, and blue card anymore. You're walking around with one card that does everything. And as I mentioned, Medicare is subsidizing or paying the insurance company. So you're looking at a really low premium here. Oftentimes, at least in the state of Kentucky, a lot of the very popular plans are zero premium. They do not charge you, the patient, anything over what they're getting from Medicare. Now, I want to be very clear that $135 a month premium, $135.50 that they take out of your Social Security, that's still going to come out. Okay, that always comes out. You always have to pay the piper. For poker players out there, I say that's the ante. And then it's anything above and beyond that. So it's the Medicare Advantage plan, you're looking at possibly a zero premium. And everything's all in one plan. And you're getting all those extra bells and whistles. And so this is the part where a lot of times people say, well, man, that sounds pretty good. What's the catch? And I say, well, I don't like that word, catch. What about there's a couple of caveats? There are a couple of differences that are very important that you understand. Number one, Medicare Advantage plans are typically going to be built on a network. Most of the plans are HMO, PPO. There's a type of thing called PFS, private fee-for-service plan. But essentially, they're all going to be built on some kind of network. Whereas before I mentioned Medicare supplement plans, you can see any doctor in the United States that accepts Medicare. The MAPD plans or the Medicare Advantage plans, you do have to see doctors that are in their network. But these plans have been out for a while. They've been around for about 15 years, even longer in some areas, and they're becoming increasingly popular. So the networks are really pretty good in a lot of places. Obviously, it gets a little tougher in some of your rural areas. The bigger caveat, I think, to me, and what most people have more questions about, is caveat number two. These plans are built on a copay structure. Different than original Medicare that's 80-20 with a deductible. Many Medicare Advantage plans, I can't say, I have to use kind of generic language because they're different in different states. There's lots of different options even within this state. So I just like to use the word many and most. But by far, most plans are built on a copay structure that will say, okay, there's no deductible. So you at least get to get rid of the deductible that Medicare has. And instead of a mystery 20% co-insurance, and they're thinking, well, I don't even know what that's going to be, you have a summary of benefits that lists everything that you could have done at a doctor or hospital or wherever you want to go for healthcare services. And it's going to tell you exactly what the copay is. You're going to go to the emergency room, well, it's going to be $90, let's say. You're going to ride in an ambulance, it's going to be $280. Or what, each plan is a little bit different. They dial their numbers in a little bit. A primary care visit might be $5 or $10 or whatever. So you get a breakdown of what all of those copays are. Now, the nice thing is, at least now you know what to expect, right? No more surprises, no more 20% question marks. A lot of people like knowing what they're going to pay. Now, I mentioned that Medicare has a couple of requirements for Medicare Advantage plans. One, that it be at least as good as the original Medicare A and B. And number two is that it has to have a safety net that Medicare does not offer. That's called a maximum out-of-pocket. Maximum out-of-pocket is kind of like a safety net. Most plans are going to be somewhere in the neighborhood of $5,000 to $7,000. Most Medicare Advantage plans are going to have a $5,000 to $7,000 safety net. If your healthcare costs, medical costs, reach that limit, the insurance company will pay everything else for the rest of the year. So you have at least some kind of stop. Whereas original Medicare, that 20%, there is no stop. It goes as high as they say. Well, that's Medicare Advantage in a nutshell. Very quickly, I know this is a little difficult to see, and if you have questions, you or a loved one this pertains to, feel free to follow up with me after. But this is the 2019 job aid from CMS that breaks down by far the most common, most popular assistance programs that exist out there. I'll start at the top. You'll see Qualified Medicare Beneficiary, QMB for shorthand. This is often called Medicaid. It's different, but the same in a weird way. You'll see the individual monthly income limit, just over $1,000, and then there's a household income limit for married couples. Below that, you have SLMB and QI. SLMB is, they're actually going to, and what this will do, QMB will basically pay the 20% for you, okay? Like I said, it's kind of like Medicaid. It will pay the 20% for you. It also waives that $135 monthly premium for Medicare Part B. So it's a big deal for people who qualify for QMB. SLMB, the next one to qualify for, if your income's a little too high for QMB, maybe you get SLMB. They won't pay the 20%, but they will help you with the Part B premium. And then QI is also, it's the same income limits for what they call low income subsidy, or commonly referred to by Social Security as extra help. It's kind of a generic name, but that's what they call it, extra help. They will help with the Part B premium, and they'll also discount your prescription drug copays. You'll remember back to our Part B slide, that final stage, the catastrophic stage, they basically fast forward you to that. So your generics are $3 and change, and your name brand medicines are $8. Again, for people low income, and we deal with a lot of this is an absolute lifesaver for a lot of people. So these are important to realize that these resources are out there, and we're always happy to help people apply for these programs. That's it. It's a lot to try to pack into 50 minutes. I think I've left myself 10 minutes for questions. So are there any questions?
Okay. Where do you get a book? Where do you get the Medicare book?
The Medicare and You book?
Yeah.
Okay. If you just Google Medicare and You 2019, it should pop right up. I would hate to tell you to call CMS or call Social Security. If you want, feel free to email me. There's my email, McQuerry@seniorva.org, and I'll be happy to reply. Just tell me, just put Medicare and You in the subject line, and I'll just send you a PDF.
And then what is the difference between, Medicare and Medicaid?
Medicare and Medicaid, good question. What is the difference between Medicare and Medicaid? Medicare is a federal health insurance program offered by the United States federal government, CMS, as I mentioned. Medicaid is in conjunction with the federal government, state government overseas for low-income individuals. So typically, not always, there's two ways to get Medicare. Either you're 65 or you've been disabled for 2 or more years. Once you've been disabled and drawing disability for 2 years, you're eligible for Medicare. One way to think of it is Medicare is for old people and Medicaid is for poor people. You can be old and poor, and that you would be what they call dual eligible. That's you have Medicare and Medicaid. It's actually more common than some people might think. Another question, yes.
How does it apply to, say, a disabled veteran who's under the VA and disabled?
How does this apply to veterans, disabled or not? Most veterans, VA is a little bit tricky. A lot of veterans do not opt to take Medicare Part B because it carries with it that $135 premium. And instead, they say, well, you know what? I can just get all of my Medicare from VA. They'll still get the Medicare Part A, but they will decline to take the Medicare Part B. I'm not the world's biggest fan of that. Of course, to each their own. Like I pointed out on the next to last slide, there are assistance programs. So for a lot of veterans, they're low income, thinking, oh, I just can't afford that $135 Medicare Part B. I would encourage them to see if they qualify for one of those assistance programs, because they may be able to get assistance to pay for Part B and not have to pay for it. And then they would have A and B, which would make them eligible for like a Medicare Advantage plan or things like that in the event that they wanted to go somewhere other than VA or wanted to tap into ancillary benefits that they were not able to get through VA. Specifically for like a disabled veteran, to be honest, I don't know that my answer would be different, really. Once you're disabled veteran, you got access to VA. When you hit 65, you're eligible for Medicare. It's up to you to decide, do I want the Medicare A and B? Do I want to pay for the B? Or do I just want to let VA handle it? Yes, sir.
So back to the situation where someone might have Medicare and Medicaid.
Yes.
How is it determined what pays what?
Medicare, I'm sorry, the question was, how do they determine who pays what if someone has Medicare and Medicaid?
Right.
Fair to say it that way. So Medicare is always going to be the primary. It will pay 80%. Medicaid will come in and pay the remaining 20%. If someone is dual eligible and has both Medicare and Medicaid, there's a special type of Medicare Advantage plan called a dual special needs plan. Dual meaning two, because you have both Medicare and Medicaid special needs because they're low income. These plans typically they're not available everywhere. You have to check with Medicare or check with a local provider to see if there's a plan in your area. But these plans can be a huge benefit to dual eligible members because they will typically offer ancillary benefits that Medicare and Medicaid do not cover. I touched on this briefly, but Medicare, even Medicare, if you have Medicaid also, Medicare and Medicaid do not cover vision, dental, hearing, transportation, things like that. So if you're eligible for one of these dual special needs plans, it can be an absolute treasure for people. Any questions? Yes.
So just to clarify, when you talk about the FG and M Medigap plans, the 100% actually means after the 1,000 something deduction for A and 185 for B, right?
Okay,
The
so the question
remaining
is,
100%.
let's talk about the question of, just a second, let's go back to.
So also
This
like
slide right
that
here.
185, is that per
Yes, so
per per period that you are seeing a doctor, or it's per year?
It's per year. So the question is, I think maybe can we just better explain Plan F, Plan G, Plan N, and that 100%, is that before or after the deductibles? Plan F will pay all of the deductible and all of the 20%. So you go in for surgery, you walk out, and you, in most cases, you will not have a bill. Medicare will pay its 80%, and Plan F will pay anything else
That includes A and B.
A and B deductibles, yes. Plan G will pay the Part A deductible, but it does not pay the Part B deductible, and that resets every January 1st. So I usually will tell people, at least in this neck of the woods, a family doctor visit usually runs about $90 plus or minus. So let's say in January you go to the doctor for a checkup. You're probably with a Plan G or an N, or if you just have Medicare, you're going to get a bill for about $90. And then you go back next month for something else, you'll probably get a bill for about $90 for that. But at that point, you've now met your deductible. Plan G will pay everything else for the remainder of the year. Any other questions? No, okay. All right.
I actually have one other one. Just
Oh, yeah, okay.
Is this a PowerPoint available somewhere, today?
I think they're recording it, so they'll have access to it online.
Correct, and it will be put on the website,
Oh, great.
so people can view it who weren't able to see it today.
What is the website?
I'll give it to you. Oh, it's the elder care website,
The elder care
www.
website is www.uky.edu
uky.edu/hr-elder care.
So I got one more question. What about that home health agencies? When, like say, the parents get really old, maybe somebody come over. How would these, any of these cover?
That is, okay, the question is, what about home health? Which is actually a different question from what about if we need someone to come help our parents? They're elderly, they need someone to come help. This is a pretty multifaceted answer. Home health is actually a different service. Home health is an agency, a nurse, or a therapist that is coming to your home to perform a medically necessary service. Let's say you recently fell and broke your hip, and you got rehab at the hospital, and then as soon as they were able to send you home, they want you to go home. But you need someone to come to the house and maybe change the bandages, maybe do some physical therapy, make sure you're feeling okay and not having any complications, and that will last for a period of time. That's home health. I think what you're actually describing and asking is home care. This goes by many different names, but Medicare nor Medicaid, although there's an asterisk there. Medicare does not pay for someone to just come check on your parents, sit with them, fix them a meal, take them to the doctor, make sure that they're okay, check in on them. That is private pay. There
Or
are lots of
long-term care insurance.
or if someone maybe has long-term care insurance, that would pay for that. There is something called home and community-based waivers for certain low-income seniors that are on Medicaid also there, so they'd be dual eligible. There's a program called home and community-based waivers by which they would apply through the state, and the state would actually pay for some private home care at no cost and case management as well.
Hours are very few. Days are, it's not every day of the week. It's like 2 hours, maybe 2 days a week.
I think there was maybe one more question. No? Okay.
All right.
Well, listen, I
Thank
really,
you, Richard.
really appreciate it.
Man,
Thank you very
you did a
much.
great job. We learned a lot. Thanks a lot.
Absolutely.
That was really